Thank you. Thank you. Are we on? Well, good afternoon. Getting towards the end of the day. We're going to have to figure out ways to spiff this up a little bit, right?
We do.
Anyway, first of all, I want to thank the leadership at U.S. News and World Report for bringing us all together for this very important conversation. I think it's been it was a wonderful evening last night, and it's been a great day today. You know, bringing us together to share the information that we each bring to this, and also, and more importantly, to bring those conversations and move them in a way that helps us collaborate on solutions. I mean, that's really why we're here, to move that dial. So in the next 45 minutes, we are actually going to talk about the state of health in our country, and whether, listening to these three illustrious people, as to their perspective on that, you know, in terms of, is it fair? And if it is, how fair is it, and how healthy is it, or not? But as I mentioned, I'm dwarfed by these three leaders, all CEOs of their organizations, who are going to be able to bring you not just information, but advice as well, relative to real time. So Dr. Jean Acius, immediately to my left, Dr. Richard Besser, and then Cece Connolly. Welcome.
Thank you.
So I think where I'd like us to start is really just to force a little bit more context. If you could each take maybe 2 or 3 sentences to describe your actual organization and what it does, so that they have a backdrop as you are sharing some of the things that you're going to give us today. So you want to start, Jean?
Sure. Well, first of all, thank you so much. Good afternoon, everyone. We can do better than that. Good afternoon, everyone. All right. Well, my name is Jean Acius. I'm the president and CEO of Creating Healthier Communities. And throughout this entire day, we've heard around how the inequities really impact not just our health, but there's huge economic implications if we actually do absolutely nothing. So that there's a cost of inaction. At Creating Healthier Communities, we're a nationwide organization that's been around for nearly 70 years. Our vision is to ensure that every person in every community has an opportunity to live their healthiest life. However, we do believe what the data tells us, that for some communities, they experience greater morbidity, greater mortality, greater illness due to inequities, as well as significant injustices in the care that they actually receive, solely based off oftentimes where they live. So we believe very strongly that your zip code should not be a death sentence within this United States, or frankly around the world. And that there's an opportunity for us to really think about how do we as an organization work across sectors and industries to collectively solve these issues together, because no one organization can do it in isolation. So as a community-centric, community-led organization, we're working with nearly 5,000 nonprofits on an annual basis, as well as with private industry and with communities, listening and ensuring that the lived experience of those who've been impacted by these inequities are in the driver's seat, both in terms of solving these challenges, because they are the experts and they know best. And what we do is serve as a bridge between public, private, and nonprofit sectors to close those gaps. And I can get more into how we actually do that.
Thank you. Richard?
Well, good afternoon. It is great to be here. Thank you to U.S. News and World Report for this important session. I'm president and CEO of the Robert Wood Johnson Foundation, a large health philanthropy. And we are taking bold leaps to transform health in our lifetime, working with others to pave the way to a future where health is not a privilege, but it's a right. And that's our new brand statement, if you yeah. Just trying that out. Yeah. I get the review. I missed like 2 words in there, but that's, you know, I used to talk about our work in saying we're working on building a culture of health in America, and we are. And one of the things that I found really exciting today, listening to the panels, one on education, one on economics, one on maternal health, is that from our perspective, they're all health panels. Because if you're not addressing the economy and economic inclusion, and you're not addressing education, not addressing any of these things, no one can lead a healthy life. And so our focus is really on systems change. And you heard a lot about that in the first panel, because you can spend a lot of resources taking care of people and helping people who have, where the system hasn't worked for them, but we're all about working upstream to change systems so that health is truly a right.
Thank you. Cece?
Well, again, thanks to U.S. News, good friends, and we're really pleased that this event is happening today, and it has been a terrific one, so I'm honored to be a part of the gathering. The Alliance of Community Health Plans is a national association based here in Washington, D.C. All of our members are nonprofit, provider-aligned community health plans. And I pause on each of those because it's also our North Star in terms of what we believe about healthcare in this country. We believe very strongly in that payer-provider partnership model grounded in local communities. And I think it's particularly relevant for this discussion today because unlike large national for-profit companies that can be headquartered in one place, and candidly, they drop in and out of markets based on how profitable a market is in any given year. Our members are based in their communities 40, 50, 70 years, and they don't jump around depending on where they can make dough. So when they say that they're committed to those communities, it's because they're bumping into their patients and their members in the grocery store, at church, at the daycare pickup. They are very much a part of the community and the community health. So it's really meaningful to them. And so I'm thrilled to kind of dig into what some of those specifics look like. But I think that might be the relevant piece for this conversation.
Yeah, absolutely. So given that, how would you describe your vision at this point for health equity, given the backgrounds that you have, the organizations that you serve at this point and are at the top of the helm of, and given the climate that we're in right now? How would you describe that? Jean, do you want to start, and you guys can pipe in?
Deloitte released a report, and thank you for that question. Deloitte released a report maybe a year ago that talked about the cost of health inequities in this country. And it was roughly about $320 billion. And when you start to kind of think about this, again, going back to my earlier point, that there's a cost to inaction. And that cost is unsustainable long term. If we do absolutely nothing, that will surpass $1 trillion by 2040. So what we need to really be thinking about are what are the opportunities to elevate solutions that are community-centric and community-led. And what we have done at CHC are a couple of things. One is understanding exactly, to the point that was made earlier by Cece, that organizations cannot just fly in and fly out. That it really takes partnerships at the local level and really taking the time to fully understand the lived experiences of those who actually are impacted by these inequities. And that requires a long-term commitment. And that also requires creating a culture of trust and a culture of understanding and a culture of ensuring that individuals are seen, heard, and equally valued. So as part of our community-centric approach, we take the time working in conjunction with our partners to A, be invited into a community because it's their community first and foremost, and then at the same time, taking the time through listening, focus groups, and a range of different other aspects to understand exactly what are the challenges that they are experiencing based off their own specific needs. How do we start to address the barriers, all of the social drivers of health or social determinants of health that are critically important to ensure that individuals actually are able to live a longer, healthier life? And if you are able to take the time to actually hear them, you can actually start to help in a way that they see fit because they're in the driver's seat. We created a tool called the Social Driver of Health database. And what we did was a couple of things. One is the fact that through this listening, it also has to be community as well as research informed. what is the data telling us, particularly with respect to a particular community? As part of the asset mapping, what are the strengths that the community actually possess? Because I think that's the key aspect of this work, is the fact that even in communities that have limited resources, there's tremendous innovation taking place. That there's assets that are actually there. So what's the lens we're using as we engage with communities? If we take an asset-based approach, we'll actually come out with more sustainable long-term solutions. The other aspect of that too is once you actually understand what the needs are, and through that listening aspect, and you actually map out that ecosystem in terms of exactly who are just, not just the traditional partners, which I get excited about, but who are some of the untraditional partners? Because we always say, how do you meet people where they are? And I think part of the strategy for all of us, and this is something that we do very well at CHC, is to actually understand who are those untraditional partners that we can start to actually connect the dots to. Because at the end of the day, it's about the individual, right, and it's about their actual needs. And then with the data that we actually receive, we give it back to the community. Because oftentimes, communities have been accustomed to, unfortunately, organizations coming in, taking the data, right, and not even sharing what we actually did with the data. And then to also think about how do you start, once you have those elements in place, to really provide those tools to the community and those respective stakeholders in order to drive long-term sustainable change. So for us, it's about sustainability, both in terms of building the capacity enhancing elements of a community, as well as the capacity support that the community actually needs.
What would you add to that, if anything?
Well, you asked about the vision. So what I would say, Caritha, is that the problem is incredibly complex. Our vision is very simple and straightforward, and it is the ability of every single American to live their best life. Yeah. Period. Full stop. That's health, as it should be for every single one of us. Now, at ACHP, we can't do everything, so we try to prioritize. And where we are really focusing in at the moment is on maternal health, and I'd love to talk about the research agenda that we just developed around toxic stress in Black maternal health. It's super exciting work that we're engaged in. And the other priority area for us is chronic disease, specifically diabetes and hypertension. Our board has taken a pledge on those two specific chronic diseases to move the needle in targeted communities over a decade. And so that is very on the ground work, again, that they're doing, and very happy to talk about that and some policy items as well. But everybody's got to kind of find their area to key in on and try to make an impact, and that's sort of where we've landed.
Yeah, well, congratulations on that.
Thank you.
Richard, would you add anything? Or?
Yeah, our vision as well is very simple. That being health as a fundamental right, and one of the themes that we heard this morning in the first panel was that the system is working the way it was designed to work. We have systems in America that privilege some and disadvantage others, and disadvantage by race, by gender, by sexual orientation, by class, by geography. And the system is working perfectly. Yeah. And so one of the things that we're looking to do is reframe some of the conversation about the drivers in health, of health being primarily an issue of individual behavior and choice, to one being health being a result of systems that need to be changed. And one of the things that gives us some hope, and it's really important to come away from a conference like this with hope, is that because these systems were constructed by people intentionally, they can be dismantled, and they can be dismantled by people. And there are enough people who are focused on making the changes we need to see. We heard from Congresswoman Underwood in the last panel, who has just been doing terrific work to bring bipartisan support around maternal health issues and with Momnibus. There are things that even in this hyperpolarized climate that we can accomplish. But if we don't talk about the fundamental role that structural racism plays as a barrier to health, we're never going to get there. And there was a period of time 2 years ago where everyone wanted to talk about it, and now we're in a period where there's a big backlash. And one of the things that philanthropy can do, and we feel is a critical part of our responsibility, is that we need to keep talking about it. Yes. Because we're not elected. We don't have shareholders. We have the ability to stick with an issue when it gets hard.
In your respective organizations, as you were just talking about the health equity and everybody talking about it, and that's really true. And certainly people over the last 4 years have felt that they have become very much in the know about what health equity is, certainly as a word, right? They say it comes off their tongue very easily. But as you talk about, so if you break it down again as you're disaggregating the data, so yes, okay, I understand what health equity is, but what does that mean and how do you operationalize it in your organization? That takes on a whole different sense of conversation, right? And I was just wondering from your perspective, what that means to you in terms of the operationalization and the conversations that you have with people. Especially SDOH, right? People say SDOH, like, oh yeah, they know it, that's great. The good news about COVID, we were talking about this at lunch, is you put all those words in other people's vocabulary, which is wonderful. But I'm not sure that they still have internalized the true meaning, and I know some of us are still internalizing it. But so I still come back to the same question and the operationality of it.
I think part of it is the ability, and we heard this from Gary this morning during one of the earlier panels, is to mirror storytelling with the data. And to really, at least internally as well as externally, with the work that we're doing at CAC, is to really humanize this. And I will give you an example. Residents in Georgetown, not too far from here, their life expectancy is about 94 years old. If you go to Anacostia, which is just a couple of miles away, it's about 67. Think about that. And what I would like you to also think about is the fact that literally you're talking about nearly 30 decades in terms of the difference of life expectancy just solely based off where you live. Yeah. So if we could start to address the issues of housing, of education, of the workforce, of healthcare, of transportation, that actually starts to close that gap. And if I were to ask you, what did you do in the last, for those who can answer this question, what did you do in the last 30 years or 27 years? And imagine if you didn't have those 27 years. Does that seem fair to you? And I think it gets to the point that Rich is talking about, that this has to be a right and not necessarily a privilege. Because what we're talking about here is not just the economic aspects of the work, but we're also talking about the lost opportunities for families to create memories, for you to watch your grandchildren grow older, to be able to play cards with your friends, to create the memories that matter most to you. So the ability to talk about the work and the mission of the organization and personalize it in a very meaningful and intentional way, I think is critically important. And then just really quickly, how that shows up externally. During Black History Month, one of our biggest initiatives is the Black Birthing Initiative. And for Black History Month, we decided that we were going to feature the lived experiences and the stories of doulas each day. And because doulas are so critically important to the workforce. And I just want to give our team amazing kudos, many of them are here, for this. This caught the attention of the White House and HHS, and the team was invited to speak at the 2nd Annual Black Maternal Health Summit. So the ability to personalize is critically important, and to consistently communicate how the mission actually impacts your work at all levels in the organization. I heard someone said earlier today that each employee is an agent for health equity. How do we actually operationalize that? Yeah. I mean, we have systems through performance and things of that nature, but the ability to operationalize and make it meaningful, I think is critically important.
Yeah, that would be very powerful. Yeah. Cece, how at ACHP, how are you and the members of ACHP, what are some of the other things that you're doing to improve patient care?
Yeah, thank you for asking, and maybe I'll just offer up a couple of specific examples to make it very real for the audience. So one is that our members have really broadened their concept of health, if you will, and it's very much not medical care. You know, in many respects, once you've ended up in the hospital, there's been a lot of failures along the way. You don't want to end up in the hospital. None of us do. So for instance, I'm on my way up to Pittsburgh this evening, our member UPMC health plan up there. They focus an incredible amount of time and energy on housing and on employment. So they have a program where they are literally creating and opening up job opportunities for their Medicaid beneficiaries. Because terrific that their Medicaid is there and that provides access to some health care, but even better is to have a job with that, and a job with, frankly, better benefits than Medicaid. So that's helping lift people in the community up and really giving them some economic empowerment that then can lead to better health, as the studies have shown. UPMC also very creatively has gotten a number of Section 8 housing grants over the years and have been able to not only get individuals into housing, but then have provided what are called wraparound services. So in a number of these locations, there may be an employment center, there may be a healthcare clinic, there may be a pharmacy, whatever those different needs are. Perhaps it's transportation to where jobs are. And by the way, this is a win-win, because not only is it terrific for the individual and the family who are now have a safe place to live, but it is saving on the healthcare side of the equation about $6,500 per person per year. And it's pretty rare that you hear about healthcare being, saving money these days. Right. So that's terrific. We also have across the country, so many of our members have created food as medicine programs, or some of them call them food pharmacies. So literally a prescription to go somewhere and get food. And typically what they're doing is providing food not just for one individual, but for the family for the week. And that's when you can really start to see a measurable difference, very fast, by the way. Both housing and food are two of the quickest interventions for improving the health of an individual. It's really remarkable and exciting to see that kind of quick impact.
Yeah. Well, interestingly enough, just given the way that you articulated it, it once again shines the light on the business case for diversity, right? In its own way.
Absolutely. And I probably should have prefaced so much of this conversation with the way that we think about this at ACHP is often who is at the table or who is not at the table.
Right.
And I can tell you, as a gal who spent 25 years in daily journalism in this town, generally covering politics, I know what it's like to not be at the table and not be in the room. So I'm personally very sensitized to that. So we go to great lengths to make certain that everything that we're doing, I mentioned the PCORI grant that we're doing on toxic stress and maternal health, the entire advisory committee for that initiative was Black women, including doulas. So that's how you get a different kind of conversation and different outcomes.
Yeah. Speaking of outcomes, Richard, were you going to add something? I was going to ask you the next question anyway.
Please.
Okay. I was just wondering, how do you measure and track at Robert Woods Johnson, how do you measure and track outcomes in terms of your initiatives? And along those same lines, relative to your overall scope initiative, which really you're always quoted as saying healthcare for all, right? Which at this point, so of course it's always been healthcare for all, and then we're able to at least get it out for a little while in terms of, hey, there's this whole underserved community that really has special needs, et cetera. We could talk about it that way, and here we are back again for, well, maybe you got to find another way to talk about it. But you're right smack dab in the middle of where maybe we should be right now, and maybe you could help with that.
Yeah, I hope in the future, instead of us being thought of as healthcare for all,
yes,
we're thought of as health is a right for all.
Yes.
Because everyone in America could have health care, and we wouldn't be a healthy nation.
Right.
If we're not talking about economic inclusion, if we're not talking about what it takes to have a healthy community, if we're not talking about an equitable education system, we're not going to have a healthy society. So for us, this whole idea of measurement is a real challenge. So we have established what we call generational goals. Because we know that the change we feel we need to see in America is something that will take a generation or more. It has taken us hundreds of years to get to where we currently are, and dismantling systems that are inequitable, that are unjust, will take a long time. And then undoing the harms, the legacies of those systems. So our generational goals are focused in 3 areas. One is around equitable and accountable public health and healthcare systems. And we know that the healthcare system in America today is not equitable. That structural racism is rife throughout our healthcare system. Right. Our second generational goal is around economic inclusion for family well-being. Because we know that if families have the resources that they need, they will raise healthy families, and that our current economic system is not designed, whether we're talking about the care economy or the tax system, it's not designed to provide families with what they need as resources. And then our third is around equitable and healthy communities. And there, a lot of our work is looking at really the legacy of intentional segregation in America. Mm-hmm. Our communities are New Jersey is one of the wealthiest states in the nation. We're national philanthropy, but in the state we're a large state philanthropy as well. And New Jersey, as one of the wealthiest states in the nation, is also one of the most segregated states in the nation. And it's not by chance. It is a result of a GI Bill that excluded 1 million black GIs from home ownership. It's about the various ways in which communities have prevented mixed income housing coming through. It's because our education system in the state is funded off property taxes. And so you see these inequities that are through. So for us, there's the long-term vision of what we're looking for, but there's also the short-term ways that we're looking. So we do a lot of work in the policy area around health care for all. And one of the areas we focus on is Medicaid expansion. So the Affordable Care Act did wonderful things, and then it did some things that weren't quite so wonderful because it needed to in order to get passed. And one of those things is that it allowed states to decide whether or not they were going to expand Medicaid to individuals who were above the poverty line, but still didn't make enough money to afford health care or were in jobs that didn't provide health care. We're one of the only wealthy nations that ties your health care or health insurance to your job. That needs to change. We need universal health care. But in the meantime, expanding Medicaid is something we focused on. And we have grantees that have done incredible work to whittle the number of states down that haven't expanded it to 10. So in North Carolina, we funded the American Cancer Society Action Network as one of our grantees. And one of the things they did was work on shifting the narrative around Medicaid, of who gets Medicaid in America. Because there's a narrative that Medicaid was just for unworthy, poor black people in America, which is, you talk about a racist narrative. But the narrative shifting to, well, you realize that most elderly people get their care through Medicaid. Mm-hmm. Disabled people get their care through Medicaid. And the majority of people who get Medicaid are white. Well, North Carolina expanded Medicaid. So we'll take it as a win, while we're working on narrative change around who in America is truly worthy and is worthy of health. Because that's a fundamental narrative that if we don't change that, it's much harder to affect any of the other change.
Can I chime in on a related
point?
And we very much agree with respect to Medicaid. And so thanks to our team working with the administration during this period of Medicaid redeterminations, the administration did allow plans to take many more sort of flexible approaches to get in touch with people, which was a very positive thing. We want to make sure that those kind of policies continue. But there is another very real threat on the horizon. During the pandemic, Congress extended, sort of as part of the emergency crisis measures, if you will, these enhanced tax subsidies for working Americans that purchase their own health care coverage on the individual exchange. So if you kind of think about Medicaid, working families, and then just one notch up. So these are still folks that are not necessarily getting insurance from their job, and they don't have much money to go and purchase. So by enhancing these tax credits or subsidies, millions more Americans got themselves coverage and got care. Those enhanced extensions are due to expire at the end of next year. And so we are very much focused on urging Congress. This is a bipartisan, real family issue here. It is an economic and health threat to these families, and we need to continue those subsidies, because without it, those folks probably are not going to be able to purchase any sort of coverage.
Right, wow. We didn't talk about this a lot in our prep, but you've each brought it up, so I want to just address it a little bit relative to policy. How would you recommend that people here get involved in policy and legislation? And also, I keep going back to what Jennifer Jones said this morning, and you mentioned it, around the structural racism piece and the systemization of that has plagued us forever. And I'm just curious, where does that fit into the equation of the narrative and how we move the ball forward? Mm-hmm. Anyway, Jean.
I'll just continue on the track, particularly on the Medicaid front. So I could not agree more, both in terms of the need to expand Medicaid and also to look at ways in which we expand coverage across the country, because that's critically important as part of the foundation for trying to get to a much more equitable society. In addition to the Medicaid expansion, I think the other aspect of that too is also looking at the opportunities to reimburse for what type of professions. Mm-hmm. And what I mean by that, for example, doulas are not currently getting reimbursed, particularly through Medicaid. And there's such a critical workforce within that infrastructure, particularly to address maternal health. So we do have some opportunities to do that. There are some examples, I think, the other thing I would just throw out there in terms of exactly how some states are trying to address the issues of equity and advance it. We just recently had an amazing conversation with the Moore administration in Maryland, and they have something called, it's called Just Communities. J-U-S-T, Just Communities. And what they're basically doing is identifying those communities within the state of Maryland, those neighborhoods where there's disproportionate impacts of disparities across a range of different factors. And what they're saying is the fact that given the prevalence of these conditions in these particular communities, which takes into account food insecurity, housing instability, coverage, home ownership, and the whole 9 yards, how can we start to prioritize state funding to align with the system change that actually needs to take place? Mm-hmm. And I thought that was such a game changer, mm-hmm. Because it's a very intentional approach to get at the structural racism that has historically plagued our particular state. I live in Maryland. But there's also other examples mm-hmm. In terms of exactly how can we start to identify those innovations, again, across all different types of communities that are showing promise to addressing these gaps as relates to the social drivers of health. And then lastly, I'll just quickly say this. We have a Black Birthing Initiative, and it's been in a pilot for about 18 months. And the part of the goal is to address the stressors that trigger preterm birth. In about 18 months, we're in 4 different sites, and we're addressing the social drivers of health. We have nearly 400 Black women and birthing individuals who are engaged in this initiative. Mm-hmm. And what we've actually found through our preliminary data are a couple of things. One is the fact that nearly 71% of the Black birthing individuals through this program have given a successful full birth. According to CDC, the national average for Black women is 55%. We've also found, particularly looking at our baseline data and the change in about 18 months, that nearly 80% of those who have participated indicate that there is no longer food insecurity. 57% are receiving housing support. Mm-hmm. And then critically important in terms of potential cost savings, just looking at this cohort, about $2 million in cost savings to the healthcare system. So these type of innovations are happening across the country. How do we elevate, amplify, sustain those so they can become scalable? Imagine what we could potentially do. Right.
Yeah, my next question was going to be, how do we get that? How quickly do we get to move that in front of the right people so that we can make those changes? Right. That's the other question. I don't know if you've had experience with that.
Yeah, you know, when I think about policy and policy change, I think it's important to think about it at all different kinds of levels. So there's the federal policy changes that Representative Underwood was talking about. There's state, there's local, and then there's also policies within institutions. And one of the things that we're focusing on when we look at issues of equity within the healthcare system is working with institutions that are interested in building more equitable institutions. Yeah. So we have a health equity tool that organizations can use to see how they're doing in terms of their equitable transformation. And it's got 7 different areas, but it looks at organizational commitment, community engagement, data. Are they collecting the right data to be able to disaggregate by the relevant demographics? Is there transparency so people in the community can see what's being done? Is there follow-up and change? That's a really, I think about that as policy, because within every organization you can look to see how equitable is your own institution. And then at the big level, we're doing work to ensure that our agencies are collecting the data that we need to see. So we've joined others in supporting changes at the Census Bureau to collect proper information on disability. Because if you're not collecting information on disability, you're not going to know if there's health disparities by disability. And we've worked with OMB and joined others there in calling on them and supporting their efforts to revise their race and ethnicity standards. These are things that all tie to policy, because once a policy is enacted, nothing has really changed. You then have to make sure it's enforced, and that there's follow-up, and that you're looking at the impact of that policy change. And you've heard a lot of us talk about data, and throughout the day there's been a talk about data. And data is critical to accountability. You want transparency around data, but just having data isn't going to get there. Data tied to the right story leads to change.
Right, exactly. So I guess it comes back to doing what we can, where we can, right?
That's right.
Whenever we can. So we are down to 3.5 minutes. Jasmine, I don't know how you ended up 4 minutes to go. You're a much better person than I am. What keeps you optimistic about health equity, about the fact that we are going to be able to really, truly have health equity? Cece, I'll start with you.
Oh gosh, in this town that can be challenging some days. Let me just say, events like this, first of all, your previous panel, which was so incredibly inspiring and energizing, and the work of Congresswoman Underwood and others on the momnibus, the doulas, those are the very, I'll call them the crunchy real bits that kind of keep me moving rather than the big. And if you don't mind, I'm going to take 30 seconds on your policy question, because there's one I want to flag for this audience that's not getting the attention that it needs to get. CMS, very focused on equity. We're thrilled. We applaud it. We support it. They rolled out something in Medicare Advantage called a Health Equity Index. It is supposed to be a way to reward health plans in Medicare Advantage that are doing better on health equity. Unfortunately, in the drafting of that regulation, they've come up with these minimum thresholds to be eligible for the reward. So what's happening is that the smaller community-based nonprofit players simply don't have enough people to hit the baseline thresholds, so they're not even going to be able to compete in the Health Equity Index. So we're really very troubled about that. We think that there's a fix. I know this sounds pretty nerdy and pretty weedy, but if you want the federal government to use taxpayer dollars to change outcomes in an area such as this, you have got to at least ensure that everybody is able to compete in that. Not that they get a pass or a break or an advantage, because right now, the people that are going to win are the largest players, not necessarily the ones that are on the ground doing the work. So I just wanted to put in that plug.
Great, thank you. I'm glad you did. Richard, optimism.
Yeah, I get up every morning and I can't wait to get back at it. And I'm optimistic. I've spent my entire career in public health working in different sectors. And these past 4 years, for the first time, I feel we're having the conversations that really matter, because we're not talking about health disparities. We're talking about health inequities, and we're talking about the systems that are driving those inequities, and we are talking about solutions to that. And I'm seeing people we support across the country and others that we don't support but we cheer on, doing the hard work to help our nation live up to its potential. And that gives me lots of optimism.
Gene, you get the last word.
Well, for me, I think that it's two fronts. One is the fact that there's a lot of innovation taking place in communities across the country, but we have to be willing to actually look for them. And as my Chief Health Equity and Impact Officer constantly says that there's no such thing as a hard-to-reach population. They're just hardly reach. So we want to really think about intentionally, how do we meet people where they are? And what gives me hope is the fact that there's resilience, even in communities that have limited resources. But we have to adopt and ensure and embrace an asset frame to actually engage with communities and ensuring that they're driving the solutions. Okay. And that gives me hope.
Well, on that, we're going to end because, I think on a good note, very positive. Thank you so much, all three of you. Thank you.
Thank you.